Aloha, everyone. Good evening. I want to welcome you all to Queen's Free Speaking of Health lecture series. Tonight's lecture is called Chronic Kidney Disease and Treatment Options. My name is Lisa Sakia. I'm with the Queen's Health Systems, and on behalf of Queen's, I welcome you all this evening. It is now my privilege and pleasure to introduce to you our speakers for this evening. The first person I want to introduce is Dr. Amuda Palanisamy. If I could have her stand, let's give her a warm welcome. She is a transplant nephrologist here. She went to medical school and did her internal medical residency at Cornell Medical College at the New York Presbyterian Hospital in New York City. She got her nephrology fellowship she did her nephrology fellowship and transplant nephrology fellowship at Columbia University, New York Presbyterian Hospital in New York City. From 2012 to 2017, she was an assistant professor of nephrology and an attending transplant nephrologist at Wake Forest University in North Carolina. And since January of 2018, she has been the transplant nephrologist here at the Queen's Transplant Center. That is Dr. Amuda Palanisamy. Next, I'd like to introduce Dr. Makoto Ogihara. He is a liver, kidney, and living kidney donor transplant surgeon here at Queen's. He received his MD at the University of Tokyo School of Medicine. He did his residency in general surgery at the University of Hawaii. He did his transplant surgery fellowship at Stanford University Medical Center. He is board certified by the American Board of Surgery. He has been a transplant surgeon in Honolulu since 2007. He is also the medical director for Legacy of Life Hawaii. I had asked him this earlier, a couple years ago. I hope it's still true. You enjoy spending time with your family playing golf, guitar, drums, skiing, and doing scuba diving. Wow. That is Dr. Ogihara. And I'd like to introduce our guest. We have two guests first I would like to introduce, and that is Colin and Robin Kumabe, a husband and wife. Let's give them a round of applause. Colin is a recipient, and Robin donated her kidney to him. I'd also like to introduce Alan and Dora Young. If you could stand, please. They are a brother and sister, and Alan received his kidney from his sister Dora, and they're going to share their stories later this evening. Right now, I'd like to welcome onto the stage Dr. Amuda Palanisamy.
Thank you, Lisa, for the introduction, and thank you all for coming tonight to learn more about an organ that's very dear to me, the kidneys. There we go. Okay, so I think when you ask people, where is your brain or where is your heart, people point immediately to the right area. The kidneys are a little bit more mysterious. They're sort of fish-shaped organs that and come in a pair. They're kind of bean-shaped, and they sit in your upper belly area. They sit right behind the back muscles, and that's why often when people have a kidney stone, it's more kind of flank back pain. They're pretty well protected by the rib cage as well. Ooh. Okay, so what do the kidneys do? The kidneys function to remove waste from the bloodstream and excess water from your body. And they combine the waste and water to make what's called urine. When the kidneys work properly, you have exactly the right amount of water you need in your body, and you also have the right concentration of some critical chemicals. So sodium, salt, potassium, phosphorus, and calcium are some of those. The kidneys also help control blood pressure. So they secrete a hormone, and a hormone is a chemical substance that kind of acts as a messenger to other parts of the body to do something. So the kidneys make a hormone called renin, and renin causes the blood pressure to rise to make sure that the blood pressure is at the right level to keep blood delivered well to all parts of the body. The kidneys also help tell the rest of your body to make red blood cells. So they help prevent anemia. And the hormone they produce to do this is called epigen. The kidneys also are important in keeping your bones healthy. So the kidney's job is to convert vitamin D from some of the food that you ingest into its active form, which then goes on to absorb calcium. It tells your body to absorb calcium in the gut, keeping your bones healthy. So what does it take to have good kidney function? So it's very important to have good blood flow into the kidney that's unobstructed. You also need, so the kidney has several hundreds of thousands of individual units that actually filter the blood and get rid of these chemicals. And you need each of those units to function properly. You also need an unobstructed pathway for the urine to come out. So what are some common risk factors for chronic kidney disease? The most common cause of chronic kidney disease here and in the US is diabetes. Some other risk factors are high blood pressure, a family history of kidney disease. Certain ethnicities are at higher risk for developing kidney disease. These include African Americans and Asian Americans as well. Obesity is a risk factor, smoking. If you have protein in the urine but normal kidney function, you are at risk for developing chronic kidney disease. And certain autoimmune diseases, for example, lupus. So if you have any of these conditions, you really should be getting screened for kidney disease pretty regularly. And screening typically involves a simple blood test and urine tests. Okay, so now that we know everything that the kidney is involved in, what happens when the kidneys do not work? So something that's really hard is that usually in the early stages of kidney disease, there are no symptoms at all. People feel fine. And most often, it's actually detected by a physician doing blood work for another reason, and they find an abnormal kidney function. And even when kidney failure advances, I think that's another thing that's a little bit confusing for people is that the urine output doesn't come down until really the end stages. So what's happening is your body is getting rid of water, but it's not clearing the blood of chemicals well. So what's in the urine isn't the right stuff. Now, when kidney failure progresses and becomes quite severe, you can have a whole host of symptoms. So you can develop anemia or low red blood cell count, high blood pressure. About 80 to 85% of patients with chronic kidney disease have high blood pressure. You can have excess fluid buildup, which ends up in your lungs or your ankles, legs, that area. People their brains may not function as well. They may have less concentration, and when they're measured on different skills, it may not be good as compared to normal. Nausea, vomiting, decreased appetite are common towards the late stages of kidney disease. And very advanced kidney disease, you can actually go into coma and have seizures. Okay, so what can we do to keep your kidneys healthy? And this is true if you don't have kidney disease, or even if you already do have kidney disease. These are all important things that we all need to do. So exercise, and it doesn't matter what form of exercise, just get up and move. So what I usually recommend is 30 minutes of vigorous exercise. Get your heart rate up 5 days a week. You want to eat healthy and maintain a healthy weight. So specifics on that, lots of fresh fruits, lots of fresh veggies. Don't add salt to your diet, low salt. You want to stay away from all sorts of processed foods. So the chips, soda, all of that. Anything that doesn't look natural or real is probably not good for you. You want to stay away from restaurant foods because they tend to be high in salt, right? That's why we go to restaurants, because the food seems tastier. But it's really high salt, high fat, and lots of sugar. So you want to stay away from all of that. Prepare your own food I know all of this is not fun, and it's easier to take a pill, but trust me, you want to prevent kidney disease. And then maintain a healthy weight. So everybody should know their BMI, and there's BMI calculators online. It's so that your weight is adjusted to your height, and make sure you want to be ideally under 25, I tell people. Ideally even lower, but I'll take 25. Okay, so avoid sugary drinks and choose water. Water is great. And avoid even diet drinks, because diet is better than regular, but there's all sorts of chemicals in diet drinks. So really choose water. I ask people to try and aim for a urine output of about 1 liter, so that turns into about 1.5 liters to 2 liters of fluid intake if your kidney function is normal. And as you progress to chronic kidney disease, you should consult your doctor because that may need to be adjusted. Okay, that was right. Okay. You want to monitor your blood pressure. So even if you're normally healthy, the recommendation is after the age of 20, you should be getting blood pressure checks every 2 years. As we age, that may need to be more frequently. A normal blood pressure is 120 or over 80. If it's abnormal, you want to meet with your doctors and figure out what you can do to improve that. First step is always a low salt diet. Okay, and then if you smoke, you shouldn't be. You should stop right away. And then you have to be careful about over-the-counter pills. So there's 2 groups of drugs that are over-the-counter that have a good association with chronic kidney disease. So the NSAIDs, which are Motrin, Aleve, ibuprofen, if you're taking that daily, regularly, you really should be talking to your doctor. Just don't... because that can definitely lead to chronic kidney disease. Also, there's newer data that some of the drugs for reflux, like Prilosec, Protonix, may be associated with chronic kidney disease. And so, again, those drugs have recently become over-the-counter, but you really want to talk to your doctor if you're using that on a regular basis before continuing to do so. Okay, so if you have chronic kidney disease, so do all of those things we just talked about, and then also some specific treatment options. So you always want to talk to your doctor about what might be the underlying cause, because treatment is very directed towards what the underlying cause is. There are certain causes of chronic kidney disease that may be reversible. For instance, if it's a medication-induced chronic kidney disease, or if there's a kidney stone obstructing the path of urine output, those all might be reversible. And so definitely talk to your doctor to figure out the underlying reason. Controlling blood pressure is probably one of the most important things you can do in preventing progression of chronic kidney disease, or at least delaying how fast it progresses. So again, high blood pressure is found in about 80–85% of patients with chronic kidney disease. You want to maintain good blood pressure control, even if it means taking several medications. Remember that a low salt diet is also very helpful in controlling your blood pressure. There are certain blood pressure agents that are specific, such as lisinopril losartan, that may also delay progression of chronic kidney disease more than other blood pressure agents, and you should talk to your doctor about that. If you have diabetes, you want to maintain very good blood sugar control. High blood sugars cause injury to the very small blood vessels in the kidneys, and it affects each filtering unit of the kidney. You want to maintain a healthy weight via proper nutrition and exercise. The more we weigh, the more demand we put on our kidneys. And finally, even sometimes, no matter what you do, kidney disease will progress, and you will need something to replace the kidneys, and that is either dialysis or kidney transplant. And I will turn it over at this point to Dr. Ogihara. Thank you all again for coming.
Thank you, Dr. Palanisamy, for a great presentation. I'm cold, so I'm wearing a lab coat. If somebody needs to go to the bathroom, please do so. So Dr. Palanisamy already covered the causes of kidney failure. These are typically top 4 causes which lead to kidney transplant. If you can eat like she recommends, if you can do exercise like she recommends, I think you wouldn't be needing a dialysis. But unfortunately, if kidney disease progresses and your kidney functions typically goes down less than 5 to 10% of normal function, you would need to start some type of treatment to help filter your system. And there are 2 dialysis modalities. The majority of people in Hawaii, about 90% of the people, go through hemodialysis. Some of the audiences today may be dialysis patients, but the hemodialysis, typically you go to center 3 times a week, and then they would use your arm tip or catheters to draw blood out of your system. Then the blood circulates through the machine and the filter. The filter cleans your blood, take away all the waste products and chemicals, and the cleaner blood comes back to your system. Usually you will sit in a chair for between 3 and 5 hours, typically 4 hours, and you will be doing this 3 times a week. So this is a hemodialysis. Hemo means blood, so it's a blood dialysis modality. There is another one. The pictures are blurred. This is called peritoneal dialysis. Peritoneum means it's a stomach membrane. So this is the stomach dialysis. Many patients refer this to home dialysis because you will learn actually how to connect and disconnect and then doing this at home every day instead of going to center and get your blood circulated through the machine. You will have surgeon place a catheter in your abdomen or stomach area and use the catheter as access to keep your system clean. About 10% of the Hawaii people, the patients in Hawaii who are on dialysis, only about 10% of patients are doing peritoneal dialysis, and 90% are doing hemodialysis. The kidney transplants, if you are the right patient, the kidney transplants, it should be the better option than these 2 machine clean options, because you will have the natural organ, the new fresh organ in your system. You don't have to be hooked up to the catheter or the machine, and then you will be making your own urine. So kidney transplants, if possible, should be sought, and then you should be considering this. When we do a kidney transplant, we don't necessarily take out sick kidneys of the patient. We have to just place a new organ in the, we call this heterotopic, but it's not in your naturally occurring space, but we place the kidney near your leg vessels and the bladder. Like Dr. Palanisamy showed a picture. Can I use? Okay. The kidney has 3 important attachments. This is the artery. So the artery has to be connected to your own artery. The vein will be connected to your own vein. And the shishi pipe, or we call this ureter will be connecting your new kidney to your own bladder. Kidney will produce urine. The urine will be transported to the bladder through this pipe. So what we transplant surgeons do is make an incision here like this. Some people get the incision on the left side, and then we put this kidney about 4 by 2 inch size into this area, and then connect all those 3 structures. Typically it takes about 2 hours. Compared to staying on dialysis, if you receive kidney transplant, you typically feel better, and because you are producing normal amount of urine, so dietary restrictions, some people who are on dialysis are told not to eat the bananas and papayas and actually all these healthy food which has a lot of potassium. Sometimes you cannot drink as much water as you want, but when you receive kidney transplant, those restrictions will go away. Also, many patients who start dialysis, they feel just a little bit too tired to continue, keep working, and then they end up in retiring or taking a disability. When you receive kidney transplant, many patients will return to work. And you are more independent. You don't have to depend on the transportation service or family members to take you to the dialysis units or help you do a home dialysis. And not for everybody. Typically for younger patients, if you receive kidney transplants, you're expected to actually even live longer. This is an old slide, but compared to dialysis, staying on dialysis, kidney transplant is supposed to give you a better survival. Our surgical team, not me, but the surgeon who started the transplant service in Hawaii, he did the first kidney transplant 50 years ago. It's easy to remember for us because his youngest son's birthday was actually his first kidney transplant day. So when his birthday comes in, we always remember, oh, that's the day that dad missed this delivery. That was 1960, actually, yeah, since 69, that's right. So next year going to be our 50th anniversary. We just passed 49 years of experience. This 1,200 kidney transplants are actually kidney transplant from deceased donors. So including kidney transplant for living donors, we have done more than 1,500 kidney transplants so far. And over the last 10 years, except the year that we moved the transplant service from another hospital to Queens Medical Center in 2012, we have done between 40 and 70 kidney transplants every year. Problems are, when you go to any kind of transplant presentation, people always to show the slides, but problems are waiting list keeps growing, but the numbers of organ donation don't, it's increasing, but it's still there's a gap, which means people are waiting longer on the waiting list. So what determines how long you have to wait? You may have heard the rumor that you have a blood type B and you may have to wait longer, which is true and false, but we checked the actual waiting time recently. Average waiting time in Hawaii is, I would say, between 3 and 5 years. You can say 4 years. Blood type, not necessarily if you're O or AB or B or A, you're better off or you're not better off. But some blood type, you may have to wait longer. So the blood type is one factor to determine how much you have to wait. And also we check not only the blood type, but to have a better match between yourself, patient, and then received kidney. We check a certain tissue type or gene type, and also how many years you've been on dialysis actually will give you a boost. I think to be fair for somebody who's been waiting, not necessarily waiting for transplant itself on the registry, but if you started dialysis a long time ago, even if you come, let's say 10 years after you start dialysis and you come to the transplant unit, you're actually collecting time doesn't start right away, but you get already 10-year point, so that we recognize that you've been waiting on the, well, not been waiting, but you have been on the dialysis for longer years. And also, probably the most influential factors is how many donors we have in Hawaii. So that'll determine how long you have to wait. And also transplant centers criteria. Some centers may have a more strict criteria to pick and choose the donor, types of donor or recipient who can be on the transplant list. In Hawaii, Queens Medical Center is the only transplant center. So if you are listed in Hawaii, there's no, I guess, the transplant center's criteria really doesn't affect your waiting time. Some patients on the transplant list, they are listed in two places, Hawaii and also in the mainland. And typically in California, but some centers in California, average waiting time could be as long as 8 years, 9 years. Some centers in the mainland may say their average waiting time is only a couple of years. So if you have the means to be double listed, that's an option to shorten your waiting time on kidney transplant list. This is about 4 years ago data, but I just compared the Hawaii, the features in Hawaii compared to the mainland U.S. Population, as of 2014, we had a 1.4 million population. This is the U.S. And in this year, during this year, 2014, among 1.42 million population, we had 47 deceased donors. This doesn't include a living person who donated kidney. In the same year, as a nation as a whole, this much people donated. Last year, more than 10,000 people donated various organs. So if you divide 47 by 1.42 million or 1 million donor population, so if you have a 1 million population, as an average in the United States, you would expect about 27 donors every year per 1 million population. In Hawaii, we had 33. So actually, Hawaii, we have a little bit more donors every year per population compared to average mainland. Then, however, the living kidney donor, the same year, we did 10 kidney transplants. This is a donation from live person, family members, friends. Sometimes it's a non-directed donation, non-related at all, but sometimes we have those donors. We did 10 kidney transplants from living persons. The same year, in the mainland, there was about this much donation. So in the mainland center, typically they have about 17 living kidney donations every year per 1 million population. But in Hawaii, living donation tends to be a little lower than mainland. That trend is still the same. So this is discussion. Okay, so who can be a living donor? Anybody can sign up in DMV or driver's license if you want to donate your organs or tissues after you pass. You can do that. But as a living person, before you die, can you donate your kidney to your loved ones? You have to be adult, and you have to be very, very healthy to protect your life after donation. There are only 2 countries in the world which is where it's legal to sell your organs. United States, it's illegal. So you're not supposed to try to, I guess, bribe your friend to get the kidney. And also, you have to really understand, I guess, the risks of donation process. So donor have to be in perfect shape and have to be really, really well aware of all the process and complications and everything. You don't have to be related. Again, most living kidney donations happen among the family members or friends, as you will hear from the one of the four people later. Actually, that's the main part of today's presentation. But the friend or actually even spouse, they're not related biologically. Sometimes you can just donate to a total stranger. This is the actual, so how many people actually are interested, and then how many people end up in being able to donate. The percentage is only about 5 to 8%. So this is a 3 months block, but this whole, it's not a calendar year, but during 12 months period, we had little less than 100 people who called us, hey, I'm interested in donating my kidney. It's a live person to their families and friends. Then actually, how many people became real donors? It's I think it's less than 10. Now we see more people who are interested in donation, so we see more numbers coming to our doors, but less than 10% will actually become donors. For various reasons, they disqualify. This is the experience of specifically living kidney donation and also the living kidney donor surgery. So the donor, if you want to donate your kidney to somebody, of course you're in perfect shape, but the surgery has to be very carefully performed because you don't have any medical benefits of donating a kidney. Just within 24 hours, we finished one donor surgery, but what I was telling the operating room staff was this person is the healthiest person in the operating room today. And after surgery, I just told everybody we made, I cannot say her or him, but I made this person a little worse because I took out 50% of the person's kidney function. So it's a big operation, and the donor has to really understand the consequences too. But we have about 30 years of experience, and we have done, I think, just the 296 or 97 today, living donor kidney transplants or donor surgeries. And my former associate used to do an open traditional kidney operations. You have to make more than 4-inch incision to remove the kidney. But over the last 11 years, we have done a laparoscopic way, and then we just passed a little over 100 surgeries so far. So we are not the biggest centers, but not really a low volume, I would say, but medium-sized centers. So these are not the pictures that if I donated or if Dr. Palanisamy donated, the stomach would look like after the donation. But I'm pretty sure her stomach is going to be 10 times better than this. But I wish my stomach is going to look like this after donation. But because kidney is about 4 by 2 inch, it's a little bigger than your fist. So when we remove the kidney, usually you have to make at least one incision close to a couple of inches. There are some pukas. These are the port sites. Most centers do this laparoscopic. So they usually this is actually the video camera port. This is the assisting port, and there should be a main port here. And this is the probably what is called hand port. Like myself, 2/3 of American surgeons use the left hand to go inside and grab the kidney, and then use the video camera. The other 3 ports do a hybrid laparoscopic procedure. Some surgeons don't put any hand inside. They use all, I think there's the port at the umbilicus too, but there are 4 holes. And they when the kidney is ready to come out from the body, they make this bikini line incision and they extract the kidney in the bag. So there are 2 ways to do this. And I don't show these pictures. These are from the internet. I don't show these pictures to prospective donors. We have actually volunteered actual patients. We took a picture of those post-donation pictures, and actually I showed these actual patients' pictures. They look as good as these internet pictures. But so who among people, volunteers who want to donate but couldn't donate? So why some people disqualify from living donor? If you have diabetes, as you can tell, diabetes is the #1 cause of actual kidney failure. So we are not supposed to remove a kidney from somebody who already has diabetes, because the diagnosis of diabetes already puts you at a little increased risk of future future kidney disease. So if you have diabetes, unfortunately, you cannot donate. If your BMI is greater than 35, then at least our center, we don't recommend doing a kidney donation. However, if you can successfully lose weight, then we will reconsider. If you have uncontrolled psychiatric issues or ongoing substance abuse, then we don't recommend doing this donor surgery. If you have a severe, let's say, past history of heart attack or heart failure, severe lung problem, if you're on oxygen supplement, or if you have to take inhalers all the time, then complications after surgery go up, so we don't recommend. If you have a major clots like economy class syndrome, or if you have a pulmonary embolism, any major clots issues, we don't recommend. If you have transmissible viral disease, HIV, Hep C, Hep B, then even if you, as long as you don't have a virus in your blood, so some patients say, oh, I'm Hep C. The Hep C doesn't mean that he actually has a hepatitis C virus in the blood. Hepatitis C virus can be these days cured with medication. But even if the virus goes away, what is called antibody remembers that you had a hepatitis C or hepatitis B. So those patients can still donate, but if you have an active hepatitis, then typically we don't recommend doing donation. Rather, we refer these patients or prospective donors to the specialist to get treated first. I think there was a patient who wanted to donate to a family member. We found during the process she was completely healthy, except she had a active hepatitis B. She didn't know. So she was treated, and then she will probably return to us soon to donate. If you have active cancers, again, cancers should be treated first, so we don't recommend doing a donation. So it's a narrow, I guess, a gate. It's not for everybody to be able to donate. But let's say if you qualify as a donor, as a living donor, then you don't have to be perfect match to your loved one. So let's say if you're blood type O, then we call blood type O universal donor, which means you can donate to any blood type. If you are blood type AB, then you have to donate to somebody who is blood type AB. It's just if you try to use the organs crossing the blood type barrier, rejection rate is just too high. And typically in this country, some other countries in the world, they do this routinely, but in America, we don't do this routinely. In Hawaii, we don't. So let's say you are blood type A, you're perfectly healthy, your wife is B. If your wife is in need of transplant, you want to donate, but blood type A cannot go to blood type B. Then what do? We have an exchange program. So we put the couple as you're already waiting in a waiting list in a national waiting list, but separate. In addition to the list, we put you on what is called National Kidney Registry. That's a kind of a living donors waiting list, then we will try to find another pair who want to donate to each other but couldn't. Let's say, if I give a simple example, if you're A, your wife is B, but if somebody maybe somewhere in the mainland, donor is B, recipient is A, so they couldn't donate to each other. But then, hey, if we swap, if we combine those couples, and then the donor in Hawaii could donate to somebody in, let's say, California, and then California, that person's donor who would want to donate but couldn't donate can donate back the kidney to Hawaii. So we've done this 3 times so far over the last about 2 years. And kidney has to go across the ocean, so transportation and logistics is a little more complicated, but it's doable. So even if your blood type and your loved one is not a match, it's not the end of the world, you still could donate. What happens after you donate kidney? This is actual kidney donors. Now I think more than actually 100,000 people have donated in this country over the last more than 50 years. And unfortunately, more than 100 people who donated kidney ended up in having a renal failure themselves. So I'm gonna say this one more time. Among 100,000 donors, actual donors who donated 1 kidney, more than 100 of people who donated kidney to their loved one actually developed kidney failure themselves, and they ended up in going into either dialysis or they received the kidney transplant themselves. If you put this in this graph, it's really thin bar, so you almost cannot see, but this is the ratio of the actual kidney donors in this country and who unfortunately developed the kidney failure. So about 0.1%. Then this number, so you have about 0.1% chance of getting a kidney failure yourself after you donate 1 kidney. Is that a bad number? You can say bad, but typically if you screen 1,000 random population, about 1 out of 1,000 population will end up in having a kidney failure anyway, even without donation, which means most of the times when you develop kidney failure, it's not necessarily because you have donated 1 kidney, but because you have developed risk factors which lead to kidney failure, such as diabetes or high blood pressure. So when you follow healthy people, previously healthy people, actually about 0.1% people end up in having a kidney failure anyway. So this table or graph actually shows by donating kidney, your chance of kidney failure, it doesn't go up that high. It's not 0. Because even if you don't donate, you have about 0.1% chance of getting a kidney failure yourself. So I don't want to scare people from if somebody's interested in donating. But by donating, if somebody sometimes asks me that, okay, so Dr. Ogihara, I'm not going to get a kidney failure myself. And then I said, you know what, 0.1% chance you're going to get a kidney failure. If you want to hear that it's a 0%, then we don't recommend doing the donor surgery. So there is risk there, but the risk is, I think, acceptable for most people who have donated kidney for their loved ones. This is a picture probably any transplant surgeon has seen at least once. It's not a Harvard Medical School, but in Boston. This is the first kidney transplant done in 1954. It was the day before Christmas Eve. and he did the surgery. Interestingly, he was not a transplant surgeon because there was no transplant surgery profession at that time, because transplant surgery was still kind of experimental. He was a plastic surgeon, and hard to tell which is which, but these are the twins, and I believe Richard was the recipient, Ronald was the donor, because they were identical twins. In those days, 1954, there was no good anti-rejection medication. So all transplant surgery pretty much failed, but because they were identical twins, they have the exact DNA, they won't reject. That's why this surgery was successful. And I believe Richard lived about 7 years after successful transplant. And this donor, Ronald, so he donated his kidney in 1954. He passed in 2010, 56 years after donation. So I think that's the longest record of, close to longest record, I think, of the living kidney donor. He died from brief stroke or some unrelated to a kidney donation. So I will put up this picture that we have a good long record of safe kidney donation. So it's safe to donate. I think this is my last.
Yes, thank you, Dr. Ogihara. And at this time, I'd like to call up Alan and Dora Young and Colin and Robin Kumabe to take the stage. Dr. Ogihara, you can take a seat there too, and Dr. Palanisamy, you can sit up on stage as well. Again, Alan and Dora are brother and sister, and Alan received a kidney from his sister Dora. And then Colin and Robin Kumabe, their husband and wife, and Robin donated her kidney to Colin. We're going to start with Alan and Dora sharing their experience. Go ahead, Alan.
Hi, I'm Alan. I found out at age 23 that I had a disease called polycystic kidneys. It happened when I was actually training for the marathon and running on a regular basis, and I was getting kidney stones. And I went to see the nephrologist, and he ran a number of tests on me, and then he discovered that I had this disease. After that, my general practitioner was notified, and they kept me on a pretty strict regimen of maintaining my blood pressure, going to see him on a regular basis, getting lab tests and all that. Normally, my disease would have progressed at about 35 to 40 years. I would have had to gone on dialysis or had a transplant. By maintaining my health and being monitored on a regular basis and following the guidelines, I was able to delay the time when my kidneys were about to fail till I was about 55, 56. About 4 years ago, I had a transplant. I had not told anyone in my family how bad my kidneys were. Even my parents and even Dora didn't know how bad they were. I kind of kept it a secret to anyone. It was only my wife and even my son didn't know much about it at that time. I didn't tell him about it. So Dora had to basically, she was a lot of times calling me up, asking me how things were going, how my kidneys were, and things like that. And when it came to the point when it came, I'm sorry, it happens every time. When it came to the point that I was a few months away from dialysis, she came up to me and said, I remember on the phone, she says, I'm willing to give you my kidney. And at first I didn't want to do it. I told her, no, I don't want you to go through this. I didn't want her to risk any of her health. I just declined it from her. I didn't want to do it. But she insisted, and she kept insisting and insisting. Then I went to talk to the surgeons. I went to do all the necessary pre-workup, and I had asked a lot of questions. I wanted to make sure everything was going to be okay for her. The transplant surgeons showed me everything, explained a lot of things to me, reassured me that things were going to be okay. And at that point, then I finally agreed to allow her to transplant. Since I've had the transplant, things have been really good. The transplant team and the transplant centers are very good in terms of monitoring us. My nephrologist monitors me on a regular basis. I see him every 3 months. The transplant team monitors me on a regular basis during the first year. Now I just see them about once a year, but I still see my nephrologist 4 times a year, every 3 months. I do blood work on a regular basis. They want to ensure that if you have a transplant, they want to make sure it remains successful. They want to make sure that you continue monitoring yourself, living a healthy life, take the medications as necessary. I've heard stories of people after getting the transplant feeling so well, so good, that they stop taking their medications because they think they don't need it anymore. But the reason why they're feeling so good is because of the medications that they're taking to make sure that the body doesn't reject the medications. So the transplant team goes through this whole process to make sure you understand everything you're going through. They make sure that you understand the medications you have to take. They make sure that you take it on a regular basis so that you don't have or face the chance of rejection. They've treated us really well. They make sure that everything that you do leads to a healthier life and leads to as normal life as possible. And after now, we've had it for about 4 years, and taking my medications and doing the things that we have to do to maintain the healthiness of my kidney becomes just part of life. You get set on a routine. My iPhone goes off at a specific time. I know when I gotta take it. I make sure I never miss it. I have a routine that I never turn off that alarm until I actually put the medications in my mouth. Because there was once in which I missed a dose of medications and I was on the transplant. I had totally forgotten to take my medication. And it wasn't until 4 hours later then I realized, and I was on the phone to the transplant team, and they said, if you have any problems, just give us a call 24/7. And I was on the phone with them, and they assured me what to do just to make sure everything would remain okay. And I never wanted to miss a medication dose again. So I got into a routine, and the alarm goes off, and everyone in the house goes, take your medicine, take your medicine. And then, so they make sure that everyone's well-versed in what you have to do. They make sure that you remain healthy, and they don't want anything to fail. So they've become very good stewards of you, and you're expected to be a good steward of your kidney.
Hi, my name is Dora. So I'm the younger sister of Alan. And what Alan said is correct. When we were growing up in his 20s, when I found out he had polycystic kidney disease, I knew that there was going to be a time in my life that I would need to donate a kidney to him. And that had remained in my mind for 30 years. So I would always ask him, how are you doing? How's your kidney? And he goes, it's stable, you know. And like he said, he never told us how bad it was. And then at one point I would ask him, I said, you know, how are you doing? How is it? And he goes, well, it's not doing so good. So I said, well, you know, tell me what I need to do, because I'm willing to donate. And he goes, no, I don't want a kidney from a living donor. I want it, you know, from a deceased donor. And so I didn't push it. So I let it go. And then one day he called me and he says, I don't know how to ask you. And I said, you don't have to ask, just tell me what to do. So I got a call from Miley from the transplant center. And then I went through the testing, and luckily I was healthy and I was able to donate. And so I was approved as his donor, and we had scheduled the surgery, and that was April 21st, 2014. And, you know, everything was successful, and it was a really positive experience for us. A lot of times people said, do you feel any different without a kidney? You know, do you feel like something's missing? And it's like, no, you don't feel like anything's missing. The good thing about it is I think I am more cognizant of my health. So what I put in my body, I try to eat more healthy. I try to drink more water now. But I just live a normal lifestyle, and I don't have to give up anything, although I try to stay away from too much protein. I give up too much, I give up some of my steaks. I eat more vegetables, and life is good. And I didn't do a lot of research prior to the surgery. I didn't go on the internet and find out this or that. I kind of left it up to the transplant team at Queens to determine whether I was healthy enough to do it or not. And, if they said I was healthy, then, I trusted it. So I didn't do a whole lot of research on the internet. I did talk to one person who went through the transplant process, and she told me that she doesn't have a different lifestyle. Everything is normal. So that was the same for me.
My name's Colin Kumabe. My journey with kidney disease is because of diabetes. I was diagnosed when I started dating Robin. We were thinking about getting married. And so that was in 1991 in September. And that's when they found out I had diabetes and all of that. And so the journey started from there. And part of the complications, of course, is your organs start failing. Diabetes just wrecks your body. So things start deteriorating. And because there's no pain or anything like that, you kind of go into this denial stage. You don't feel anything. Then in 2013, February 1st, I was feeling very nauseous at work. Then all of a sudden I started dry heaving, couldn't breathe. My body was just breaking down. I started losing consciousness. And basically I had renal failure, so they rushed me to the hospital. Before then, I was at 12%. Think about 15, 12. I had dehydrated, and my kidney function went down to almost zero. And then when they rehydrated me, it went up to 7%. I was at 7% at that point. And so my nephrologist had told me that I would have to not immediately, but I would have to go on dialysis. So about a month later, I was on PD, that one you do yourself, one of the 10%. And it will definitely affect your lifestyle. You have to be on a machine overnight. I had to do certain manuals, which take a while. It definitely affected my work life. You don't feel good. You really don't. And then what happened is, I'm gonna turn it over to Robin because the rest is there. Okay.
Hi, I'm Robin, Colin's wife. So when Colin ended up in the hospital in February, that was just a wake-up call for us all. I had asked the nephrologist in the hospital, I said, maybe I can donate my kidney to Colin. And she said, well, do you have high blood pressure? And I said, yeah, I do. And she goes, how many blood pressure pills are you on? And I said, 3. And she said, you can't donate your kidney. And so I was like, wait a second. I don't take no for an answer. Let's see what I can do about that. And so I went to my doctor. And I asked him what I needed to do to get off of my blood pressure medications. They told me that I just needed to get down to 1. And at first, what I did is he found me a blood pressure medication that had all 3 of the different blood pressure meds in one tablet. And so I asked if we could try that. Do you remember, Miley? And they took it to the board, and they said, no, you can't do that. So I went through diet, exercise, lost weight, and I finally was able to get down to 1 kidney, one tablet, and they were And then I actually went through the process again, and it was really an amazing experience to be able to get my own health back in shape so that I could, make my husband and actually the quality of life for both of us healthy. So.
Like Alan, I didn't want to accept her kidney. I didn't want to accept my kids donating their kidney. I felt that I shouldn't shorten their lives. I had my shot. I didn't get everything, but I was pretty satisfied. And then Robin had talked to Dr. Ogihara about this.
So Dr. Okihara shared the risk factors, and it really didn't seem like there was much. It was basically just Colin being able to be convinced that he didn't deserve to have the rest of his life be bad because of because of his diabetes. That instead, that the risk factors were relatively low, especially if I was healthy again. And so together we actually, September 23rd will be 2013. It's going to be 5 years since I donated my kidney to him. And it was amazing because, the 4 out of the 6 antigens were matching. So there was really very low risk of rejection. And I have to say that the staff and the doctors and everybody here, and Dr. Ogihara, amazing people. We even got to have our beds in the rooms next to each other. So they really made arrangements to make sure that everything was great. And afterwards, again, just like Dora, I feel much healthier. Both of us became healthier because of the kidney donation. And just the satisfaction, especially that, I think, of anything, is just knowing that you can actually donate an organ and help save somebody's life and still be living and actually be healthy. So that's pretty much our story.
Thank you so much. Let's give them a round of applause. And now we're going to open the floor up to questions. And if you have a question regarding living kidney donation, chronic kidney disease, just raise your hands. Okay, out in the front there. Laura's coming to give you a mic.
Thank you. This question is for Dr. Ogihara. You mentioned that the low-functioning kidney is left in the body after the transplant. So my question is, does that low-functioning kidney contribute to the entire kidney function whatsoever afterwards, however small it is?
Usually by the time you're receiving transplants, most patients are already on dialysis. If you're fortunate enough to have a living person donating to you, sometimes you can plan ahead. And before dialysis has to be started, you could go to a scheduled living donor transplant. But most patients are already on dialysis. So once you're on dialysis, your kidney functions are probably working only a couple of percent, close to 0%. And when the new kidney goes in your body, almost 99% of the kidney functions are done by the new kidney. So we don't remove your kidney because keeping your own kidneys don't harm you. But I don't think after a new kidney goes in, a functional kidney goes in, then actually your own native kidneys are not really contributing much to your, well-being anymore after transplant.
Okay, thank you.
Okay, other questions? Raise your hand. Do you have a question?
This one's for Dr. Ogihara. If I may ask about the statistics you showed earlier about the renal failure that happened. I was just wondering, for patients who donate a kidney and then have renal failure later in life, does the renal failure occur in the kidney they donated as well?
So your question is the donors who donated kidney ended up in kidney failure themselves. Is that because they donated kidney or not? Is that the question?
Oh, I was wondering for the recipient if they experienced renal failure as well.
Oh, I see. Okay. Well, you're asking medical professional level question. So when that's a very okay. I may, because it's a difficult question. I may save it to Dr. Palinsami. But so to clarify his question, the donors can go into renal failure themselves. Then you would wonder, hey, the recipient who got that kidney, the other made kidney, are they actually more likely to have kidney failure than the other patients? That's a very tough question. There is some correlation, but usually not. Usually donors who unfortunately progress to kidney failure, it's not because of their native kidney disease. Most of the times we rule that out. If you have some type of genetic kidney disease, we will rule that out before you can be a donor. However, there are certain gene types, especially in African American people, that the Kidney Transplant Society might have missed in the future. That's why there are data. If you're African American, if you become a donor, actually the chance of kidney failure is much higher than Asian or Caucasian. I think it's almost 1%, especially if you're male. So people was wondering why is that, and then they might have found a gene. So your question is very, very high level question. But anyway, is there anything more? Okay.
Okay. Oh, and there's a question there. Go ahead, sir.
How do kidney stones, if you have a kidney stone, is that an indication of problems to come with renal failure?
So did you mention kidney stone?
If you have a stone, if you have kidney stones,
Mm-hmm.
is that a red light that you're going to be in trouble with your kidney?
So kidney stones can be a cause of kidney failure if they obstruct, if they're large enough to obstruct the pathway that urine or shishi comes out. They can cause chronic kidney disease. Usually, so there are certain types of kidney stones that are more common with kidney disease due to high parathyroid hormone levels. But it really depends on the kind of stone that you have, and it may not necessarily reflect underlying kidney disease.
In my instance, when I discovered that I had kidney disease, it was because I was training for the marathon. So I was running 7 to 10 miles per day. So it basically dehydrated me a lot, and it concentrated my urine. And they figured that the concentration of the urine caused the kidney stones to occur. And the kidney stones occurred was because there was something wrong with my kidney. And if it wasn't for those stones, I never would have found that I had the kidney disease. Yeah. It was just under examination when they were testing my kidneys to find out why I was getting stones, because they couldn't figure it out, because I was eating healthy, I was exercising, running 10 miles a day, and it was like, well, why are you getting kidney stones? And until they did a more thorough exam, then they found out the reason why, and it was because I had the kidney disease. So it wasn't the kidney stone that caused my kidney disease. Actually, the kidney disease caused the kidney stones.
Okay, other questions? Oh.
You mentioned there was a test for urine and blood test for screening for kidney disease. Could you explain a little bit more about how often do you take, what kind of tests are these? When do you start testing, if you're healthy and that kind of stuff?
Sure. So there's no official recommendation of if you're completely healthy without any of the risk factors that we went over, at what age you should start screening. if you have a risk factor, you should definitely get screened. The screening involves a blood test, and they're looking at the serum creatinine level, which is a reflection of kidney function. Often the earliest sign of kidney disease is actually protein in the urine, and so that's part of the screening as well. I would say at age somewhere between 40 and 50, most primary care physicians are doing a set of baseline labs, which I would also recommend, which includes a kidney test, the serum creatinine. And you.
Usually it's part of that because I've been taking blood tests.
Yes, and you usually it's
don't know
what to ask. Yeah, yeah.
whether I had it or not.
Yeah, so I would just ask your doctor for a copy of the labs. I always ask patients to look at their labs, and then also to specifically ask, hey, is there anything abnormal on these labs that I should worry about? And then you can ask, was a kidney test done?
So protein in the urine?
Protein in the urine is often the earliest sign of kidney disease. Other things that we look out for are blood in the urine and the serum creatinine. creatinine.
Other question?
If you go to my DLS charts, if you do DLS, which I do, I get it as fast as the doctors, and I always examine my labs. I don't know about Alan, but I always, so when I go in to see my doctor after the lab, I already have the test, so I already know what they're going to tell me. So, I mean, because I'm a, kidney person, yeah, we look at all the different chemical, things, and you'll get to know. It's good to ask your doctor about what each of those tests do. Yeah, you should be informed.
Yes, I do the same. I have an account on DLS Labs, and as soon as I get my labs drawn, they'll usually notify me by email that it's ready to look, and I'm monitoring my blood tests, so I know exactly what's going on even before I see my doctor. And sometimes the doctor just wants me to do a test, and I don't have to see him. So I do it on a regular basis. I monitor to make sure everything's all good, make sure that what I've been eating is okay, and make sure that my medications are at the correct level.
Okay, Miley Reddy from the Queen's Transplant Center has some information about this as well.
I just wanted to add that the National Kidney Foundation is here as well, and they sometimes do host kidney screening clinics where they do a urine test as well, so they can provide you information about the screening test for that also.
I'm just wondering, the lab numbers, if they're coming out, I got mine right here, but I got protein as a result. That means they don't tell you how much, but where does it say, okay, you should see a specialist now?
So I would ask your doctor about it because there is a way to quantitate that. That's an initial screening. You can get what's called a urine protein creatinine ratio and also a urine microalbumin.
I think I got all those numbers. But there's so many things in here that you got to look at. And I'm just looking at this. It's not highlighted. Bold. Bold italics. So I look at ketones and protein as being H high.
Yeah. So I would definitely review that with your doctor because there may be further testing that's
because I asked them, and they said, well, you have to, take care of their stuff, but they didn't recommend me going to a specialist yet. I'm going to an endocrinologist and EP, and I don't know, number that tell you, at this point.
I see.
Is it up to
We might
something
be
that
able
they
to
know?
meet after, and maybe we can talk one-on-one
Okay.
about
Okay.
what we recommend. Just
Okay,
to
thank you.
protect your.
Is there another question right over there?
Dr. Ogihara, you mentioned about the two dialysis treatments, either at the dialysis center or at home. Is there any, which would you prefer? That if a person would go do it at home, but do they have to do it every day as opposed to 3 days a week?
So, which I prefer, okay, so my personal opinion, if I go into renal failure and before my wife donates her kidney to me, I think blood type is I'm B and she's O, so she can donate. But anyway, then I would probably prefer peritoneal dialysis, home dialysis. You don't have to be a medical professional to be able to do it, but you have to have certain environment, usually basic, hand-eye coordination skills, and also a clean environment, and usually family help too, in case you get sick. So your kidney doctor would advise you can do that or you cannot do that. This is my personal opinion. I said about 3,500 patients are on dialysis in Hawaii, and only about 10% are doing home dialysis. In other countries where medical treatment is cheaper, much cheaper than the United States, they tend to have patients go through peritoneal dialysis first. So peritoneal dialysis is a very good way, but you have to learn basic skills, and typically what is recommended is to go to the class first. I think National Kidney Foundation also gonna give you some information, but you take some steps, and then sometimes home dialysis nurse will actually come to visit your place and then make sure your place is safe to do that. And after maybe 2 or 3 visits, and if you qualify and if you're willing, then surgeons can place a catheter. And then after that, I guess maybe the actual patients maybe explain better, but month and a half or so training, 5 times, 7 times, most patients actually can master, and then they can do this. You're supposed to do this every day.
Okay, thank you.
Okay, other questions? Raise your hand. Oh, one over there.
This question is for Alan.
Yes.
You said that diabetes had helped cause your kidney failure.
No, I don't have diabetes. I have what is called polycystic kidneys.
Oh, I'm sorry, Colin. You had diabetes. And so what I wanted to find out is how you were able to then manage your diabetes, or do you still have it, or what has happened since then?
Kidney, excuse me, kidney transplant does not cure diabetes. Okay, diabetes is ongoing, and so that's a totally different disease, okay, compared to kidney disease. So
Yeah, but you took care of yourself.
yeah, so what it made me realize is that since I have part of her in me, I better take care of myself and take care of my wife. But I am very aware of my diabetes now, very, very aware, especially after renal failure. But for those of you who have diabetes, I would say start now before you even get to this point. You have to manage it really well. Take your blood sugars. I take it about 5, 6, 7 times a day. Okay, so manage it really well.
Hi. With diabetes and high blood pressure causing all this kidney issues, with a whole foods plant-based diet, and you talked about eating healthy and exercise. With a whole foods plant-based diet, would that, especially with the ECAHI program now promoting the resolving a lot of these issues, and in fact, they've had studies where kidney patients regained or increased their GFR rating. And would the consumption of a whole foods plant-based diet, Would that eliminate?
I went on that. That was the diet I went on to not only lose weight, but also get off my blood pressure medications. So that's a really great, the whole food diet though, that was the one I went on.
And they eliminate the oil, in fact. Like Dr. McDougall, he talks about just cooking with water and broth to do his stir fries. Would that eliminate poor kidney functions? Like you talked about, the protein in your urine. But with the exercise, there is hyperfiltration when you consume animal protein, which reduces that. So how would, resolve for a lot of, the standard American diet is really causing a lot of these issues where, we've gotten to this epidemic. At this stage, you said 3,500 are on dialysis today. And it's growing, as we all know. Would the whole foods plant-based diet resolve these things, along with exercise, of course?
Absolutely, a plant-based diet with exercise is probably the best thing you can do for overall health, including kidney health. Once you have chronic kidney disease, it may not reverse what's already there, but it will certainly help slow down progression. And we certainly know high-protein diets can cause injury to the kidney.
Does it matter whether it's animal protein or plant protein?
Plant-based protein is the way to go.
So you can consume more plant protein versus animal protein?
Correct.
Okay, so consume more plant protein than animal protein.
Then less animal protein.
But less animal protein.
Yes.
Okay, we have a question back here too.
I have an unusual question. Have any of you heard of that disease called mad cow disease? And if you have been exposed to it, you're not allowed to be a donor or a blood donor or organ donor. Have you ever heard of that? It has a big long name. It was in Europe in the 80s and 90s. And if you've been exposed to it, huh?
Yeah, it's Creutzfeldt-Jakob disease, yes. And yes, it's... If you have a history of the disease, usually, yes, you are not, yeah. That's correct.
Okay, thank you. One last question. I do have a question. You mentioned that potassium, foods high in potassium, that's dangerous for those who have chronic kidney disease. Why is that? And should people who are fearful they're going to get chronic kidney disease not have high potassium foods?
So if you're healthy, you typically do not have to worry about potassium. If you have chronic kidney disease, one of the things the kidney does is secrete potassium in the urine, and that function may be impaired. That's very variable, and so what I would do is ask your doctor, what is your potassium? Can I keep doing what I'm doing, or is it high, and that I need to watch those foods, because potassium is found in a lot of healthy foods, and if your potassium level is fine and you have mild kidney impairment, you may need not make any changes in your diet.
Yeah, I just wanted to say we are actually very grateful for National Kidney Foundation, especially the donors are the ones that actually get benefits from National Kidney Foundation so that we can actually go through the surgery ourselves. So that's a very big thank you very much.
Shout out to the National Kidney Foundation, which have representatives here. Thank you very much. So at this time, can we give another round of applause for our speakers this evening, Dr. Palanisamy, Dr. Ogihara, Alan and Dora Young, and Colin and Robin Kumabe. Thank you for sharing all your time with us this evening. I want to also thank Connie Williams from the Queen's Transplant Center and also the National Kidney Foundation folks who are outside with the information tables and giving away all those prizes that I see, the orange bags and things like that. I think there was that fluffy orange kidney as well. See what you missed at home. Also want to thank our volunteers, Karen Sumida and Laura Nagasawa, who is helping us out this evening. Want to share with you that our next Speaking of Health lecture is going to be on preventing falls, how to be safe. And if you didn't know, 1 in 4 older Americans falls every year, and falls are the leading cause of both fatal and non-fatal injuries in those 65 and older. That's according to the National Council on Aging. We're going to tell you how you can be safe with Dr. Sherry Kogan, who is the medical director of Queens Geriatric Services. We'll also have physical therapist Corey Kojima here, and they're going to talk about what causes falls, what you can do to reduce your risk, what exercises can help, and how you can create a safe environment so you can prevent those falls. That's going to be Wednesday, September 26th from 5:30 to 7 p.m. right here at the Queens Conference Center. To register, you can go online at queens.org, click Attend a Class, or call 691-7117. That's our Queens referral line. And on behalf of Queens, I want to thank all of you for coming, and please drive safely, get your tickets validated. It's almost after 7 though. Get your tickets validated and drive safe. Thank you, good night.